So we're going to talk here about one of the more common genetic problems that comes up on the USMLE, and that is Down syndrome. And we'll just go over a brief overview, touch on what this is. We'll go over the genetics and features, also the development of these children, the diagnosis, and remember that we can diagnose this prenatally, so you're going to want to understand how we diagnose this prenatally and what some of the laboratory features are. We'll talk about the immediate management of newborns with Down syndrome, and then some of the more long-term considerations and long-term management as these children approach adulthood. So this is the most common genetic cause of moderate mental retardation. However, the intellectual capacities of a child with Down syndrome varies widely. So some children with Down syndrome can have quite profound mental retardation, and some of them can actually be quite towards the normal range, towards the 100 normal range of IQ. So it really varies. But typically, these children are in the moderate mental retardation to mild mental retardation area on the IQ range. This is the only autosomal trisomy that's compatible with long-term life. So there's a few other trisomies that we see often, and those would be Patau and Edwards syndrome. Those are both autosomal trisomies of 13 and 18, respectively. However, those children typically don't live much longer than 6 months to 1 year. And then there's another trisomy, Klinefelter syndrome, but that's a sex chromosome trisomy. So this is the only autosomal trisomy that's compatible with long-term life, with these children living into childhood and then ultimately into adulthood. This affects about 1 in 733 children. I'm not sure if this number was 1 in 733 pregnancies or 1 in 733 live-born children. As we're going to see, I've got a statistic that shows there are a lot of Down syndrome pregnancies that once they're diagnosed with Down syndrome, they wind up actually getting aborted. So I'm not sure if this is, I'm pretty sure this is 1 in 733 pregnancies that go to term, but I'll have to look into that. This is also very notoriously associated with increasing maternal age. This is a trisomy of chromosome 21, and it's due to non-disjunction, which results in typically the egg having 2 copies of chromosome 21, and that results in 3 copies of chromosome 21 once you get fertilization and you get the other copy from the sperm. Now, what usually happens, and the reason that this is more common in older mothers, is because over time the eggs accumulate damage. Remember that women are born with all their eggs when they're born, and those eggs accumulate damage over time, and the spindle fibers become less able to pull the chromosomes apart, and allow for that only one chromosome, one copy of the chromosome is present in the gamete. So if 2 chromosomes are present in the gamete, then you're going to ultimately result in trisomy. You can also get Down syndrome from an unbalanced translocation, and so this is typically a Robertsonian translocation where one arm of chromosome 21 attaches to chromosome 14 and then vice versa. And so in that case, if you have a balanced translocation in a person, then they're going to have 1 in 4 of their gametes are going to be Down syndrome gametes. Mosaicism is another way that Down syndrome can manifest, and typically in these Down syndrome mosaics, which are a lot less common, they have less severe symptoms, but typically they present with your characteristic Down syndrome features. Advanced maternal age, as mentioned, is the most commonly encountered risk for Down syndrome, and particularly after age 35, the risk really starts going up. So this is the notorious J-curve here, and right about at 35, the risk starts going up exponentially. So you can see here that the maternal age, you go from 20 to 49, it goes up 200-fold over the time of a woman's life. So it's really at 35, where your risk is 1 in 350, and it really starts going up, so that by age 40, the risk has gone is more than tripled, from 1 in 350 to 1 in 100. And then this is another statistic here: 90% of children with Down syndrome are aborted. So some of these features here in Down syndrome, the ones I put in red here are some of the more common features that you're going to see in babies. But all of these features are relatively common, some more so than others in people with Down syndrome. So these ones that I put in the red here are all more than 50%. So the flat face, that's pretty much the same as this small nose with a flat bridge. So if you look at these babies from the side, their nose isn't very prominent, and that's because they have this flat bridge. And so it makes their face look a little bit flatter, and that's present in 90% of babies. Upward slanted palpebral fissure, I'll show you what that looks like. The eyes are just slanted upwards. Then they also have a tendency to have smaller ears that are somewhat abnormal in appearance. The epicanthal fold is another thing that the USMLE likes to throw at you. I'll show you some pictures of that. And then the protruding tongue is another thing that patients with Down syndrome characteristically have. Some of these GI features, they're not going to happen in a majority of Down syndrome patients, but it's worth knowing, because when you do see duodenal atresia or Hirschsprung's disease, Down syndrome is a common culprit. So a lot of patients who have duodenal atresia or Hirschsprung's disease have Down syndrome, but the vast majority of Down syndrome patients don't go on to actually develop these GI symptoms. But it's worth knowing that that Down syndrome children are at risk for these GI malformations. The musculoskeletal symptoms, one thing, I'll show you a picture. There's a Simian crease, which is just a single transverse palmar crease. Now, again, this is not something that always happens in Down syndrome children, and Simian crease can be present in non-Down syndrome children as well. So this isn't pathognomonic. It's not a sine qua non, but it is a feature that's seen in almost half of Down syndrome children. And then this Sandal sign, I'll show you a picture of that as well, where there's extra space between the big toe and the second toe. This short neck and redundant skin, we also see this in Turner syndrome. So it looks pretty similar, and this is actually important to know about, because when you look at when you look at the sonogram of a baby in the first trimester, you'll see increased nuchal translucency, and that is why you get that redundant skin. Also, when you do your CNS exam, these babies tend to be hypotonic, and their moral reflex will be reduced. And then some of these other features tend to show up a little later in life if they show up. And then also worth remembering that all Down syndrome children need to be screened for congenital heart diseases. So here's some of the things that you can see here, put into graphical form. Okay, so here's a child with Down syndrome who happens to be eating sweet potatoes. And so here's the flat nasal bridge. Now it's a little bit difficult to see that from this angle, but if the baby were to turn his head, you'd note that the nose is not very prominent when you're looking laterally. So you can see here that this ear is a little bit smaller. It's sort of dysplastic, and it sits a little bit low. And then here's an epicanthal fold. Here's another child here with the epicanthal fold, protruding tongue, and then a flat nasal bridge, and upward slanting palpebral fissure. So if you look at your palpebral fissure line, you'll note that it's going upwards. So go from your medial fissure or your medial palpebra to your lateral palpebra, and if you drew the line, it's slanted upwards. So you see it a little bit more prominently in this child. So draw a line from here to here, and it's upwards relative to the horizontal plane. Another flat nasal bridge, epicanthal fold, and what looks to be a protruding tongue, although it looks like this kid might be smiling too. So here's the sort of webbing of the neck. This child has a short neck and then some of that extra skin. This is the Sandal sign. So you see this in about half of Down syndrome children. So the way it gets its name from is these sandals. The little notch goes in between your big toe and your second toe, if you've ever worn these before. And so if you look at these babies' feet, they have a little extra space in between their big toe and their second toe. This is Clinodactyly. So you'll see this in some children as well. Typically it's going to affect their pinky, and it's just a bent finger. So here it is in a baby and then in an adult. So this is the Simian crease here, and so normally there are 2 transverse palmar folds, but in a lot of Down syndrome children there'll only be 1. Here's another one. So all Down syndrome children are going to have developmental delays, usually by a few months or so compared to their normal peers. They tend to have a particular difficulty with expressive language, although their ability with receptive language tends to be a little bit easier for them. Their self-help skills also tend to be significantly delayed relative to other children, so things like potty training, tying their shoes, and so forth. And then they also have increased risk of psychiatric comorbidities, about 18 to 38%, and these tend to be behavioral issues. And that's probably due to their reduced cognition and slightly more difficult time understanding commands and directions. And this is going to relate to how severe the mental retardation is. Typically, though, this is amenable to pharmacotherapy. Some other psychiatric comorbidities that may be present include depression. Some of these children will have symptoms consistent with autism spectrum, and then some of the more severe cases can have intermittent psychosis. As far as diagnosing Down syndrome, typically it's done prenatally. To formally diagnose it, it's going to require chromosomal analysis, which is going to show you the 3 copies of chromosome 21. But in many cases, like I said, the diagnosis is made prenatally. So we do screen for this obstetrically. The first trimester, you can look at the nuchal translucency, and in Down syndrome, it's going to be increased. I'll show you a picture of that. In the second trimester, for all women, we do either a quad or triple marker screen. And in this case, we're looking at alpha-fetoprotein, HCG, estriol, and then in the quad screen, we also get inhibin A levels. And this allows us to look for various illnesses in addition to spina bifida. So in that case, you're going to have elevated AFP levels. In the case of a suspicious nuchal translucency or biomarker screen, then you can get chorionic villus sampling. This is a little bit more accurate. So that'll be done for mothers who have suspicious results on their sono or on their marker screen. You'll also want to offer this to women who are of advanced age, advanced age as far as being pregnant, so that's going to be any woman who's over 35, and then women who have a past history of a baby with Down syndrome. So this is the nuchal translucency. You do this at about 11 to 12 weeks of gestation, so right towards the end of the first trimester. And the normal range of the nuchal translucency is up to up to 3 millimeters. So this is a normal nuchal translucency, and then this is elevated. So note that the translucent area is increased here. And this is consistent but not diagnostic of Down syndrome. So I put the quad marker screen here, but you can also do the triple marker screen. It just wouldn't include the inhibin A. So for Down syndrome, your AFP and your estriol are going to be low, but your HCG and your inhibin A are going to be high. Now note that Down syndrome and Turner syndrome have pretty much the same results. So the mnemonic here is Downs and Turners are high, H-I-G-H. So your HCG and your inhibin are going to be high. And then Edwards and Patau syndrome look a little bit different. So with Edwards syndrome, H and E are low. So the E is for estriol and for Edwards. And with Patau, your AF Patau is high. So your AFP is high, but the rest are normal. So that's your mnemonic, and that'll help you with USMLE questions that address any of these 4 illnesses. Remember that AFP is also going to be increased in spina bifida and your neural tube defects. It'll also be high in omphalocele as well, anytime you have exposed tissue. Management for Down syndrome is, of course, going to be your typical routine newborn care, and then also to attend to any comorbidities. Typically, these will be like failure to pass meconium due to GI issues. You may have a tracheoesophageal fistula. You'll also want to get thyroid function tests. These babies are at risk for hypothyroidism. You want to consult with a pediatric cardiologist to investigate for a congenital heart defect, and then also with a pediatric ophthalmologist for vision screening. Long term, these children are going to need a little bit extra inspection, so they're going to have their vision and hearing checked annually. They're at increased risk for cataracts, and a lot of these children will also need glasses. They're at risk for strabismus and refractive errors. They'll need their hearing checked annually. They have a 70% risk of serous otitis media, which can ultimately lead to a need for a hearing aid. They'll get annual thyroid function tests. It's also important to remember to chart their growth on a special curve for Down syndrome, because otherwise it's going to appear that they're failing to thrive. But Down syndrome children, they grow slower, and ultimately they're not going to reach a normal height. They're going to be shorter as adults. They'll also, as they get older, they'll need counseling regarding diet and obesity. They're at risk for obesity, and that, of course, is going to carry with it all its comorbidities. And then these children, if they're going to go into contact sports, they're going to need radiographs for atlantoaxial subluxation or dislocation. And then, of course, also if there's neck pain or any suspicious neurologic symptoms. So remember the association with atlantoaxial issues. For their social functioning, they're going to get speech and language therapy from a very young age, and then physical and occupational therapy to help them function in adult life. The life expectancy for Down syndrome is in the mid-50s, so that's actually pretty good compared to what it used to be, and that's mostly due to better standards of care, the fact that we're able to treat a lot of those congenital heart conditions, and also that we have better ideas of what their comorbidities are, and we can expect some of these things. They are at risk for early onset Alzheimer's, and they have about a 2 to 3 times higher risk of Alzheimer's compared to the general population. So the reason that they have that increased risk is because the amyloid plaque protein is actually expressed on chromosome 13, and so since they have 3 copies of that, they're actually going to produce more. Another cause of death in Down syndrome patients is ALL, so leukemia, and again, their life expectancy has gone up because we have developed better treatments for things like ALL as well. So as you can see here, people with Down syndrome have a wide range of functioning. It's really important for you as a physician, whether you work in pediatrics or as a family practitioner or in internal medicine. It's very important to put these people in coordination with occupational therapy, with social workers. These patients, in many cases, will be able to have some kind of job. Some of them will require living in a house with other people that are disabled, although some are able to live independently. So it really just depends. But again, it's incumbent on you as a physician to make sure that you're coordinating their care because these people are going to require sort of a multicentric approach. They'll need a lot of different specialists to help them out. So if you have any questions, go ahead and write a comment below. See you next time.